delighted to be here this morning to join you. I hope more people may be coming from the other sessions. And it's a very big honor for me to be asked to give the keynote here to this academy. So why does it matter what happens in India? I think the world does keep its eye on India, not just the UK, with whom we have historical bonds, but many world programs will be running from India, as well as China and some of the other big players. Because, let's face it, you have the second largest population in the world, you are one of the most diverse nations. You're potentially, for many countries, a very strong trade and economic partner, and you will know that our Prime Ministers are great friends at the moment. Your Prime Minister filled Wembley Stadium. We don't see that very often in our country. And I think that tells us something we need to be thinking about why, and indeed, what are the issues that may arise when big corporate businesses are interested in a country and are interested particularly in healthcare. I have always respected the intellectual and the cultural outputs of your beautiful country and drawn on them often for my own inspiration and refreshment. And I have many colleagues working with me in the UK who come from Indian background and are part of enriching our culture and our thinking. And we've seen just in the speaker before us, we have many academic leaders from India contributing to research in science and medicine around the world. But you have huge challenges. We all have challenges about economic growth and stability and addressing social inequality. But again, when I look at India, I think you have some of the biggest challenges. And I was just before coming into the main hall in the rural slot and heard 2 or 3 extremely impressive but very challenging discussions about the health in rural communities in different parts of your country. And there are questions being asked about health systems achievement in India. And a lot of interest, perhaps more constructively critical interest, both within your own ministry, from the big player, World Bank, WHO. I'm going to make some references to some of their documents. And so the interest is not just economic, but it's about what is being achieved here, and is it good enough for what is needed? And at the bottom of all this, and at the top of all this, are actually the needs of the patients. So that's why I think what matters here matters to the rest of the world, because we want to understand if India can do healthcare well, and if so, how they did it. And your patients will really want to know the answer to that question too. So the main health challenges, I know you know this better than me, but again, to remind ourselves, you have quite high maternal and neonatal mortality, although it is dropping. Still relatively high rates of accidental or self-inflicted harms. Infectious disease control is still a challenge, but at the same time, you have the same pattern as my country, most countries in the world, that as some parts of the population get healthier, live longer, they get more non-communicable diseases, and especially that's also influenced by lifestyle in some sectors. There is the challenge of addressing mental health issues as well as physical. Sometimes mental health doesn't get the same attention or the same position. Sometimes it is stigmatized, and so that's a challenge for health services. And there are also the environmental aspects, whether that's climate, whether it's work, environmental pollution. People keep saying to me in Delhi, have you smelt the air this morning? And there's one example. And of course, environmental instability, so natural disasters and displacement of populations, health inequalities. And this has all been very well put by my colleague, senior colleague, Junior Tudor Hart, who wrote about the inverse care law, whereas the problem for our health sector is that often the best medical care is in the populations whose health is already quite good. And the most needy populations with the least resources get the least good care. It's called the inverse care law. Health financing challenges. As I have done more international work and more policy work, I've really had to learn more about what financial systems drive healthcare and how they can assist us to provide good primary healthcare. And this is World Bank stuff about India, a fairly recent report, it's in the bottom of the slides, I think 2011 to 12, that India still is characterized by relatively low public sector financing of its health sector and by high levels of out-of-pocket spending. So a few quotes: significantly below its global comparators in terms of public expenditure. Out-of-pocket's about 70%, one of the highest percentages in the world, with significant impoverishing effects. A culture of straight to specialist, by which I mean secondary care hospital specialists. We, of course, are specialists too. And exacerbated by the rural-urban shift and the workforce disparities, and the way that you have to choose where or you have chosen perhaps in different states how the financial incentives do or don't assist the provision of strong primary care. I know there is some progress. I've also read something about experiments. It is for you to tell me how well they're working. That's one conversation I'd like to have. But many countries are making new choices about better coverage through government-assisted health insurance schemes. You have the National Rural Health Mission. There are specific state examples I read about. And most of these are aiming to strengthen universal coverage. I'll come back to what that means. Prioritizing those who are already below the poverty line, avoiding avoidable morbidity and mortality, and trying to reduce impoverishing or catastrophic impoverishment when somebody in the family becomes sick. And of course, one of the conclusions, and this does apply wherever I'm going in the world to health service strategy, is if you can prevent it, then people don't get so sick. And guess what? It isn't so expensive. So you get better quality of life for the people, and you reduce your costs in terms of hospitalization. Easy to say, difficult to do. So what do we know about making a health system stronger? So if you're taking a big picture, if you are a medical leader, and people in the academy are medical leaders or future leaders, then the question is, do I know what needs to be done to change this? And the goals, I think, the value of this is to have a couple of clear messages in your head. What are we aiming at? We're aiming at health systems that are accessible. And that means not just geographically accessible or physically accessible, but also things that people feel able to use, feel able to come to the clinic, feel that it will welcome them and be a place that they can enter and use, that's affordable and is of good quality. And the financial packages, however they're driven, need to cover the needs of the people, make their use of the service appropriate, and avoid catastrophic impoverishment. And key aspects in this, I think, are 5, possibly 6. So you've got to have a strong workforce in all the sectors that have got the right skills to do the job. It's no good saying this and then having a weak primary care sector where people turn up and the nurse is not properly trained, or the doctor is not properly trained, or they don't have the infrastructure to do it. Or, indeed, that they don't know what they're doing because there is no monitoring and data collection. And to do that, it's really important to have good leadership and good governance, which is why we as doctors, in a sense, have to know, I think, something about this. In my medical school, we teach public health, we teach health economics, we try to develop these students' leadership skills because we say, as a professional, you will have to advocate and you will have to decide how money and resources should be delivered or chosen or prioritized. And you will also have to do gap analysis if you are not getting the support that you need to deliver the service that is right for the people. So we have to know something about this as well as the clinical side, and that's what the leadership and governance part is about. Definitions of universal health coverage. I'm putting this down because actually I hear it is a little bit slippery as I go around the world. So sometimes people will say, we have universal health coverage here. And what they mean is there is a basic, community health worker, perhaps, somebody that people can go to and get some help from, which is great. But if you look at the WHO definition, you will see that it is a little bit more than that. So here are the three. People can obtain the health services they need without suffering financial hardship. In the UK, we do have a private sector, and people choose to use it if they want some additional service. But the NHS, which is taxation funded, mostly, some out-of-pocket payment for prescriptions and drugs, but mostly from taxation, is able to meet the health care of the people's needs without them suffering financial hardship, example. And that covers preventive, health promoting, as well as curative and palliative services. And here, of course, this is where WHO has very much been saying, particularly in recent times, primary care is crucial. And we've got to integrate this service, the preventive, the communicative, and so on, at primary care level and close to where the people can get that service. So that's the full definition. And within that, again, we have to think about equity for the reason that I've said, meeting the needs of rural population is a different challenge, often from urban. But even within big cities, as we know, there will be parts that are very well provided and parts that are very underprovided, or indeed where the healthcare may be quite weak. There is a difference in medical education, there have been equity issues. And again, I've already heard some presentations here that I think really are important about this. When I first went to medical school, we did 1 week in community setting in 6 years training. And one of my tutors said to me, next week is to show you how not to practice medicine. That was the 1970s. Actually, the transformation of medical education in my lifetime has been about getting people outside hospital setting, getting them to learn about these primary healthcare issues, learning from the patients in their community. And we have seen this shift, the abbreviations I want to just draw your attention from saying, let's have medical education. It's a bit more oriented to the community. That usually means some public health included in the course. To actually being community-based, so having students training in community settings, having part of residence programs being in community settings. And then the big question is community-engaged medical education. And my colleague Roger Strasser has written again about this recently, about saying, what does it really take for the people to take some ownership of their healthcare and the training that young doctors and nurses receive? And that, again, is a very different equity orientation. Gender matters in healthcare. Women's needs, men's needs are different in the healthcare system. Again, in the rural setting, we were just talking about this. But also in the way that people work in medicine. As we see more women coming into medicine, we also need to be thinking very clearly about how we can support their careers and their development and their contribution to the healthcare system. Income levels is an equity issue, and educational social opportunities. So again, think universal health coverage, think equity. They're the two take-homes on that. Why? Well, because actually, if we do that, then the health system really does start to strengthen. If you have good primary care that is equitable and is working in the way that we've just been discussing, you see that the outcomes are better. And this is the best work was from our colleague Barbara Starfield. And I'm sure some of you will already know this. These are some of the take-home points, and please read more, discuss, whatever. This is what interests governments, of course, because then again, governments will say, oh, really? Oh, maybe we had better start doing some business deals for primary care rather than just for the hospital sector. So money talks, and we have to show the evidence about why this matters. And then, of course, I come to us. So what does that mean for doctors? Why do we need family medicine? Let's remind ourselves what we call a family doctor. Somebody who's trained to deal with people from all the life stages, This does vary a little bit from country to country. So even in Europe, some countries have a different system, for example, for children. But our WONCA statement is generally a generalist who can deal with everybody in the family at every stage of their life with a medical need, and offering, again, this service that is comprehensive, accessible, allows continuity over time. So I had a discussion yesterday with a colleague who was saying, well, we've had family medicine in our hospital sector for 20 years, I think he said. And I have seen in other countries family medicine start in training in the hospital sector, running the outpatients, doing the first point of care. But one of the big differences, do you have continuity with those patients over time? Do you register those patients? And can you provide your whole set of family medicine skills? So again, these are things I want us to keep in our mind when we're making decisions about how we develop the training and where people train and what is the scope of their practice. Because in some ways, if we don't have that breadth and the continuity and the commitment to the community over time, then maybe we can't exercise our discipline for its full benefit or full interest for us as well. What do I know about Indian primary care? Well, I know about your organisation and I know about this conference. And of course, we've been having conversations with Raman on the executive for some time, and it's fantastic to see what you have achieved. And I look back at the work that you're doing, and also, for example, my colleague Michael Kidd, who gave you greetings yesterday, I think, was here 2 years ago, and you were running this big consultation, and that's a fantastic way to do things. We run commissions and consultations in the UK, and that's a really good way to have a big discussion with different stakeholders, and especially with politicians about, you know, why would you do this? What does it mean? And have a proper thinking piece. So I was very impressed by that. You're establishing different trainings in family medicine, diplomas, new residency programs, and it would be great to see a map of what's going on all over India. Maybe the Academy has one, I just haven't found it yet, but even the examples I've heard, it sounds great. Working with interns, residents, developing faculty, and work on assessment, so knowing when you've reached the competencies that you need and you aspire to deliver your discipline. All that, I think, completely fits with what in WONCA we would say are the building blocks for family medicine. So it's really important as a country moves forward in this to have specialty status, to have a postgraduate training. There was a point in my own country where you could choose to do MRCGP, but you didn't have to. And people could come out of the medical schools and go into general practice, and that was all. And now it isn't the same. There was a point where now everybody has to do postgraduate training, just like the physicians, just like the surgeons, just like obs and gynae. And that has really changed the status of the discipline. So I think not only just for the status of the discipline, but also for the delivery of the service. If you are giving people postgraduate training, they graduate with a higher competency skill set, and that is more likely in a modern system to add value to the medical care. So aiming for postgraduate status, I think, is an important building block. Aiming to have an academic faculty in all medical schools, another of WONCA's mission statements is every medical school should have a department of family medicine, because there you get that training, you get the teaching opportunity, you get the research opportunity, and it begins to develop the strength of the academic presence with the students to lead these changes so that students and residents then are being given community placements, the academics are helping the colleagues in clinical to supervise, and we also contribute from the academic side to policy development at government level. The third building block is to develop the political will. So this is why your leaders go off and have these big conversations, why I think the minister is coming later. You had somebody else from the ministry yesterday, and that developing the discussion and the network and making the case again and again for primary care and why it matters for universal health coverage is a really important part of our work, and also our work with WHO. And making sure that our work really is integrated with community-based teams and has this breadth. So another challenge when governments have run things as vertical programs, you know, the malaria program, the TB program, the maternal child health program, is to make that verticality integrated at the level of the community with the healthcare system. So that's a fourth building block. The fifth one being getting professional representation. Are your leaders on the academy, the medical academy? We have an academy of Royal Colleges. We have 2 places at that table that we had to fight for. Do you have representation into the medical council? All those sorts of battles and developments are part of building the discipline, and they are things that it's important to try to achieve. So if you want to know how you're getting on with it, it's not too difficult. You'd say, so have we got evidence that we've got postgraduate specialty training program? In my country, that's delivering about 40% of the doctors who work in the NHS. What's the curriculum? Does it fit with family medicine? You know, have we got a roadmap that we're trying to assess ourselves besides things I've already said? Is training for family medicine done in family medicine? That's a difficult one if you haven't got family medicine very well embedded in the system. And we've all had to start somewhere. So actually often it's been, you know, community doctors, public health doctors, sometimes other physicians who've been the first group to supervise residency in family medicine. But it quickly needs to move on so that family medicine doctors are being grown by other family doctors. And are there academic units in the medical school, and have you got a professional specialty organisation? And of course, if you do travel, you will see that some countries have parts of this. Your country will have parts of it. My country still hasn't achieved everything it needs to achieve in any way. And in fact, our NHS, that's another story you might like to discuss with me, but I'm not doing that talk right now. But all these things, you know, you can map yourself and say, how are we doing on this? So let me take, last 2 slides are a little bit about the World Organization of Family Doctors, and I just wanted to say one other word about equity. We have special interest groups specifically looking at health inequalities issues and developing our expertise and thinking about what our responsibility is as family doctors and sharing good practice about how we, at our level, clinically and organisationally, can work with this. Women and children's health, of course, particular priority for many countries and in the Sustainable Development Goals. And then rural, and John Wynne-Jones is here, the chair of our rural party. I know you have representatives and networks into that group, and that's a big issue that WONCA has taken as part of its platform for equity issues. So how can we help your academy and you as family doctors? I think the strengths in our growing situation, we have 130 plus, Garth, I should have asked you to update the numbers, but I think we now have more than 130 countries who have full member status within WONCA. And if you include groups who have affiliation and other parts, last slide, Chair, is have up to 150. That started from 13 when the organisation started, and we've seen a lot of new members, and we've even got new applications sitting to be processed. So family medicine is growing around the world, and that's really encouraging, and it gives us then a global scale for political influence, so we can also do some work in a region on behalf of individual countries, and individual countries will help us to influence other situations and to support other growing membership bodies. Together, that means we have, we can be an instrument for change. We've got big numbers and we can quote those. And we try to do what I call thought leadership. So the whole point of us having these discussions is to take our thinking forward and to share good practice and what's worked elsewhere, and to collect the data to demonstrate that what we do really works, because this cause is needed, I believe, by everybody in the world. I think everybody needs a family doctor. I think every community needs family medicine. And once they get it, and it's a good service, they know that is true. So I'm sure that we can be inspired by doing what we know is right. And the key activities of WONCA, in a way, just like your membership organisation, are education, exchange, building up new networks, supporting each other, developing your special interests through special interest group working parties. That's how I started out in WONCA, was that I got involved in one of the working parties, and that took me out just of my own country or region and gave me a much bigger global perspective, and I'm very glad it did. The young doctor movements, I think, are absolutely fantastic. Raman has walked in right on cue. He's our young doctor representative. And, of course, working with WHO. So behind every achievement, there are the people who make it happen. And we are only individually ourselves, but when we work together, we're that much stronger. I particularly want to thank Raman for his leadership and contribution in the executive in WONCA, and clearly in this setting here. I also had already put slide of Jyoti and Ramnek on, because I've seen them as great champions and very supportive to WONCA's work. And the executive and my own member organisation, the Royal College of GPs, and it's great for me to have colleagues from our member organisation here today, and I know that they've been doing good work with some of you guys to try to help develop family medicine here. So thank you very much. That's it.